And now I introduced my student, colleague and the student. She was my student. Now, Dr.Saba Al Fallahi. She is مسؤولة عن البورد المصري في مركز القلب. تفضل في عنوان المحاضرة PERIPATTUM CARDIOMYOPATHY. Please try on time. Thank you.
Assalamu alaikum. My topic today is about peripartum cardiomyopathy on the guideline of 2025. Actually, peripartum cardiomyopathy is not so common condition, but it is life-threatening. And in the new guideline, it takes a large space and attention with some updation from the guideline of 2018. We will start by the hemodynamic changes of pregnancy. We all know that during pregnancy there is some changes in the hemodynamics, like increased plasma volume, increase in the cardiac output, and decrease in pulmonary vascular resistance. These changes are well tolerated in normal lady, but patients with pre-existing cardiac disease, they usually face problem. We should also know that there is some ECG changes and some echocardiographic normal changes in pregnancy, like BR shortening and some flattening of the T wave. In echocardiography, we may face increase of the LA size, increase in LV in diastolic dimension. These changes are reversible, and with pregnancy, the patient goes to her baseline. In the new guideline of peripartum in pregnancy, they give the peripartum cardiomyopathy a large attention and space in the guideline in comparison to the previous guidelines. Starting by the definition, it is defined as the presence of signs and symptoms of heart failure with ejection fraction less than 45% without any explanation. So it is a diagnosis of exclusion. That occurred during peripartum period or following termination or miscarriage. So in this guideline, they didn't give what we know the time. They didn't the time period, which is 1 month, the last 1 month, and up to 6 months post delivery. They make it open. So they didn't emphasize in this point, and we should also concentrate on miscarriage, because a lot of patients they have miscarriage and they come with cardiac symptoms, and we didn't concentrate that this could be a peripartum cardiomyopathy, because it is abortion. Take care in this point. The incidence of peripartum cardiomyopathy is very widely. The big variation is related to ethnicity and geographical region. It is more in the African and Eastern South. Mechanism of peripartum cardiomyopathy, it is multifactorial. There is multiple theories. Genetic play role, environmental, inflammatory, oxidative stress, and generation of anti-angiogenic prolactin, which would make endothelial dysfunction. From this, the last mechanism, this is the role of bromocriptine. Bromocriptine was studied in peripartum cardiomyopathy, and in the latest guideline, it was put in class 2B. We will discuss later. Risk factor of peripartum cardiomyopathy: malnutrition, family history, the presence of previous peripartum cardiomyopathy, age less than 20 or more than 40, ethnicity, geographical region, as we said before, multiparity, smoking, diabetes, and use of tocolytic therapy. Actually, in the new guideline, in pregnancy guideline, they make modification of the WHO classification of maternal risk factor. What's important for us is that peripartum cardiomyopathy is in the category 3. It's in class 3. Regarding investigation, we know that pregnancy can come with signs and symptoms that resemble a cardiac disease. So we should emphasize in the history and examination to catch the patient who are really cardiac patient. ECG is important. Echo is of paramount importance. We can also natriuretic peptide. Regarding X-ray or cardiac MRI, they are classified as class 2B if needed, if we didn't reach the diagnosis because of harmful effect on the fetus. Recommendation, it is, as we said, echocardiography is class 1. Measurement of BNP is class 2A, even in patient with, when the patient come to your clinic and she has history of previous peripartum cardiomyopathy, it is wise to ask for pro-BNP even if the patient is asymptomatic. The outcome of cardiomyopathy is promising. Actually, up to 60% of patients recover in the first 6 months. The range is wide from 25 to 60. As we said before, it is related to geographical and ethnicity. We have poor prognostic factors. These factors are alarming factors. They give us an impression that the patient will not recover, maybe not recover. Like what? If the patient presents with low ejection fraction at presentation, if the patient comes with hemodynamic instability during presentation, patient with previous diagnosis of peripartum cardiomyopathy, the patient who is more than 40 or she is less than 20, in Middle Eastern and African, if the LV in diastolic dimension more than 60, if the patient has biventricular dysfunction, and if she has a prolonged QT and ECG. These are bad alarming signs that the patient may not recover completely. Management of peripartum cardiomyopathy. Actually, what is very important in the way they emphasize in the last guideline, and I think also in 2018, they start the term of pregnancy heart team, but in this guideline, they give it a special importance. The pregnancy heart team include multi-specialization like cardiologist, gynecologist, anesthesia, and pediatrician, nursing care, even psychiatric, because most of the patients go into postpartum depression or due to stoppage of lactation or due to her symptom by themselves. So multi-specialization should be included in the management of patient. So the term pregnancy heart team is very important, and it was emphasized in this guideline. And the job of this team, not only during delivery or during pregnancy, no, it should start from preconception. From preconception to assess the risk factor and give the patient counseling regarding the possibility of pregnancy or no, and optimization of medication before pregnancy, and also during pregnancy, during delivery plan, and postpartum and long-term prognosis. So it has a wide range of tasks. New recommendation is yes, the pregnancy heart team is class 1. I don't know what you mean by class 1. We have for the student we have 3 types of recommendation: class 1, class 2, class 3. Class 1 is mandatory, it should be done. Class 2 we have class 2A and class 2B لأن احنا هنتكلم بعدين في الميديكيشن. 2A and 2B. Class 3 it is harmful and you shouldn't do it. Class 2 قلنا في معانا A and B. A according to the risk and benefit. If the benefit more than the risk هنقول class 2A. لو الريسك أكثر من البنفيت هنقول 2B. فالبريجنانسي هارت تيم it's given class 1. Okay. طيب مانجمنت قلنا هنبدأ بالبريجنانسي أو بوست بارتم. في during pregnancy we need to adjust the heart failure medication. We know that most of the medication for heart failure are class 3. We cannot give them in pregnancy, so the patient should be under supervision of cardiology follow-up. Regarding postpartum, the most thing that they emphasize in this guideline is the bromocriptine. Bromocriptine was given a class 2B. Class 2B is still beneficial. Actually احنا قلنا الريسك more than the benefit في 2B. لكن they put it in special group of patient. Which patient? Patient with severe heart failure. The patient with severely decreased ejection fraction we prefer to give them bromocriptine. Why? Because bromocriptine was studied and showed a promising effect in patients with peripartum cardiomyopathy. Actually, it was studied in 2 doses. It was given either 2.5 milligram for 1 week, or 5 milligram for 2 weeks, then decreasing the dose to 2.5 for another 6 weeks. فكانت عملوا 2 groups of patients. There was no significant statistical difference between the 2 groups. So we can't give it for 1 week. So, okay. What's the drawback of bromocriptine? Bromocriptine can cause thromboembolization. So it's procoagulant. Any patient given bromocriptine should be given anticoagulation prophylactic dose. هذه النقطة أعتقد it is mistaken يعني missed most in our practice. I don't know, are you giving يعني heparin or enoxaparin in patient with bromocriptine routinely, or you are missed؟ في سؤال يعني في حد بيجيب دائما الانتيكوagulation؟ ما أعرف. أنا صراحة أنا أشوف دائما I see a lot of patients coming with bromocriptine. مع البروموكريبتين هذه لازم قلنا الآن bromocriptine is class 2B to be given, but to give anticoagulation with bromocriptine is class 2A. فلازم إذا خرجنا من هذه النقطة لازم نخرج بها فاهمينها كويس جدا، مش بس نحفظ إن إحنا ندي bromocriptine. لا، bromocriptine ممكن ندي up to 1. It's enough. 1 week is enough. صح. الاستدي قال ممكن توصل ل 8 weeks، لكن ما فيش big difference. ف 1 week is enough, but you should give enoxaparin prophylactic dose with it. It's class 2A. طيب. So the management of patient with heart failure احنا حنقسمهم إلى 2 classes according to the heart failure severity. If severe or less severe heart failure. Patient with severe heart failure, if they come with cardiogenic shock, we'll give them inotropic support. They recommend the inotropic levosimendan or dobutamine, milrinone. The class is upgraded from class 2A إلى class 1 في new guideline. Patient, if the patient come with يعني heart failure but not in acute heart failure, معانا 2 groups. اللي patient اللي هم already delivered, we can give ACE inhibitor, we can give beta blocker, we can give MRA and SGLT if the patient is not going to lactate her baby. Regarding patient who is still pregnancy, we can give only diuretic, beta blocker, we can give hydralazine and nitrate. These are the only available allowed medication. طيب الريكومنديشن ايش قلنا هذه تكلمنا عنها اللوم لوكلورويت هيبارين. طيب والبروموكريبتين تكلمنا عنها. في نقطة أيضا مهمة إنه to add anticoagulation if the patient has decreased ejection fraction less than 35%. إحنا دائما نعطي if there is thrombus، بس الآن it is mandatory, it's class 1 to give anticoagulation therapeutic dose if the ejection fraction is less than 35% in peripartum. Regarding the management delivery, mode of delivery, vaginal delivery is the standard. Any special situation we will ask for cesarean, like if the patient come with severely reduced ejection fraction, so in that case we will advise for cesarean section. Otherwise vaginal delivery with good special care يعني. Regarding breastfeeding, there is paucity of data, it's controversy. Actually, I think it's according to the severity of heart failure. The patient is in severe heart failure because the breastfeeding is another load.
باقي دقيقة.
Okay. Pregnancy, lactation is another load of the تعمل increase in metabolic demand for the mother. So if she is in severe heart failure, so it's class 2B to ask her to يعني stop breastfeeding. وبروموكريبتين حيقوم بالواجب يعني it will help. Okay. Regarding the most important thing now is contraception. Don't leave your patient unless you send her to a gynecologist for counseling and contraception, because it is not allowed for any patient with peripartum cardiomyopathy to get pregnancy unless the ejection fraction goes toward normal. And after that, even before allowing her to go to pregnant, we should ask her to make a stress echocardiogram to assess the contractile function. في آخر نقطة وهي مهمة في الجايد لاين، إنه in the previous guideline احنا كنا محتارين ندي الميديكيشن حق البيريبارتم cardiomyopathy if the patient improved. وش معنى الامبروفمنت؟ if the ejection fraction goes back to more than 50. طيب اعطيه لمده كم؟ اذا البيشنت if the patient recovered and reached 50% ejection fraction لمده كم؟ في البريفيس جايد لاين كانت مفتوحه ما كان في كلام واضح. in this guideline they emphasize that it's class 2A to give her at least for 12 months after recovery. فمعانا الان duration معك patient recovered يعطيها 12 months وبعدين اسحاب الميديكيشن gradual discontinuation of medication. Thank you very much.
شكرا دكتور سعاد. انا بحكي كلمه على موضوع البروموكريبتين عشان ما يخسر واحد صراحه انه ستيل ويك انديكيشن ماشي. ف وي ار ذير از current trials ماشي.